Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Hi, everyone, and welcome back to the Skin Sync podcast. This is Bucci Nita, dermatology PA from the Atlanta area, and I'm so excited to be joined today by my Elevate-Derm colleague and today's co-host, Jennifer Connor. For those who don't know, Jennifer is usually behind the scenes with the Skin Sync podcast, but now she is here in the studio with me. So thanks for coming, Jennifer.
Yeah, my pleasure. Thanks for having me.
And I'm also excited to welcome a new guest to the podcast, Dr. Riley McLean. She is a board-certified dermatologist and Mohs surgeon at UMASS Memorial Health. She's been in practice for 7 years, and for the last 2 years, she's served as medical director of Green Initiatives for UMass, which is a health system encompassing 7 hospitals and serving over 500,000 people per year. Outside of her clinical role, she is a mom to 4 and a soccer coach and avid gardener. So Dr. McLean or Riley, welcome to the podcast.
Hi, thanks so much for having me. It's great to be here.
So, as I mentioned earlier, you are a Mohs surgeon, and we want to kind of get some tips from you. I think we all interact with Mohs surgeons pretty regularly in clinic. Every practice I've ever worked in over the last 16 years has been with a Mohs surgeon in some capacity. But I think there's things that we don't know. For those of us that don't do Mohs, there's a lot that we don't know, a lot of useful tools that hopefully you can teach us today. So my first question is really the basics. Let's start with, how do you recommend us taking photos for biopsies, marking the biopsy site? Are there certain things when it comes to the biopsy itself that are helpful for you as a surgeon?
This is like the ultimate soapbox. So I so much appreciate this because so many of my referrals, I don't do general dermatology. So most of my referrals are coming from my colleagues, and having high quality photos is hugely important. They've actually studied it, and the likelihood of identifying the wrong spot, like the patient identifying the wrong spot, in some studies is about 6 to 10%, and in some studies it's up to 30%. And so even though some patients are very reliable, and then even though in some cases we can see a really well-defined scar or residual tumor, oftentimes that's not the case. So really high quality photos makes a big difference in terms of the day starting successfully and finishing through successfully. And what that looks like is one photo from further away so that you can kind of figure out where you are. Meaning, if it's a photo on the arm, it's nice to see. If it's a forearm, it's nice to see the elbow and the wrist. If it's a photo on the scalp, it's nice to see both ears and a nose. And then maybe one closer up, because that helps us triangulate if there's little nevi around or something like that. And in terms of marking the spot, it's really hard when you're doing a biopsy when you don't want to leave purple pen all over someone's face and know that it's not going to come off very easily. But 4 spots around it versus coloring in what you're actually going to biopsy. So coloring in the surface of a basal cell, something like that, is really, really helpful. One thing that I've noticed in recent years with the transition to more EMRs is that some EMRs auto-populate a location based on where you click on the homunculus. And oftentimes we see those are wrong. And so it might be a matter of being careful and diligent and checking what you either are putting in automatically or what you may have your staff putting in automatically. But the photo counteracts that a lot. The photo is probably the most reliable thing.
So I'm really surprised to hear you say that as low as 10%, but up to 30% of patients may misidentify a location of a biopsy.
Yeah, the shocking thing to me was that um, in that same study, surgeons misidentify it also. And I
Interesting.
think the stat was something like 6% at least, if you didn't have a photo, would misidentify, even with like the named location. So if humans make errors, and so as much evidence as you can have to counteract human error, the better.
Yeah, absolutely.
Wow, that's a little bit terrifying. So I'm always really good at taking photos, thank goodness. Any tips on just biopsy technique, especially when we're biopsying, obviously, for skin cancers that we know we're likely going to
Yeah.
refer for Mohs surgery?
Yeah, excellent question. So I like to think about biopsy in terms of what am I suspicious for and what is my goal. And so, if you're thinking something melanocytic, partial biopsies are awful. And only because you never know if you're going to catch the worst part of it, if you're going to catch something that they say it's a moderately atypical pigmented macule, and then the other half is a melanoma. So if you can manage to do a broad shave of something pigmented and get the whole thing, that's by far a better way of diagnosing it. And if you're suspicious about a invasive melanoma, the biggest key is not to transect it. Or if you're gonna, sometimes it's inevitable that if you have a very deep melanoma, you're gonna transect it, but you wanna make sure that your depth of biopsy is beyond the depth that you would need to decide if you have a sentinel node or not. And so the first thing I think of is, what is my suspicion? And if it's something melanocytic where I'm worried about melanoma, I'm swinging for the fences and I will deal with the scar afterwards. If, on the other hand, I'm thinking something like a non-melanoma skin cancer, my bigger concern is preservation of the normal skin around it, getting enough to diagnose the cancer, but not getting so much that I'm widening what I would have to take out with surgery. So if you picture like a 5 millimeter basal cell, I don't want a biopsy that's 8 or 9 millimeters wide, where then the surgeon is going to have to go around all that normal skin as well. So I kind of think what your leading diagnosis is important. And then that second piece of what's my intention, because I'm sure all of us have had people who get surgical fatigue where they're just done. They've had, you know, umpteen non-melanoma skin cancers. And in those patients, sometimes the intention is, if I can scoop and get rid of this thing, it's going to save that patient another visit. And so I think the intention matters too. The last piece is, sometimes for cosmetically sensitive areas or cosmetically sensitive patients, a punch biopsy is actually going to be better. Because if you think about what you do with a punch, you remove the tissue, you close the sides, you shrink your overall biopsy size, and then that shrinks what the Mohs surgeon then has to go back and get. So I will oftentimes do that, particularly for cosmetically sensitive women on the face. I find I do a lot more punches. So,
Find it interesting, when I'm ruling out a skin cancer, especially on a patient who's cosmetically sensitive, who's so hyper focused on the scar, and I have to
mhm,
kinda say, "Well, I'm worried about you having a cancer, right?" And of course, I'm
mhm,
worried about the cosmesis in a way, but I want to rule out the cancer first, and we'll worry about the cosmesis down the road, and by the way, I have really great Mohs surgeons who will take care of that for you. But sometimes you
mhm.
have to sort of talk them off the ledge, right? Just doing the
Yeah.
biopsy.
Right.
Yeah, it's true. And that is always good for, I know we're probably going to talk a little bit about that kind of thing, but that's always good for us to know if the patient is of that particular ilk, to know that in advance.
Yeah,
For
absolutely.
sure.
And one thing I thought was really interesting, those were all really great tips, but specifically when you're doing a biopsy, to not, obviously you want to get an adequate sample if you're doing a shave, but not to kind of overdo it. Because I never really considered that the Mohs surgeon is now having to go around that entire biopsy site to try to ensure clear margins. So that's really helpful. Thank you for that. When we have a lesion, diagnosed skin cancer, basal cell or squamous cell carcinoma, how do we figure out if it actually qualifies for Mohs? I know historically I actually have the app on my phone. It's the Mohs appropriate use criteria app, the Mohs AUC. It's really helpful, but I wanted to know if that's something that you typically use. And also, are there any red flag words on the pathology report that really indicate to you that this is an automatic Mohs surgery patient?
Yeah, that's a great question. I still use the AUC app all the time. Like, I think I probably bust it out at least several times a week. I mean, a rough rule of thumb in my head is, if it's on the head, it's gonna be Mohs. And if it's on the trunk, then you have to think size and aggressive criteria, and rather than keep that all in my head, I think the simplest thing is to use the app. But there are certain words on path that, even if you know they're destined for Mohs, would change my criteria for how quickly I do something. Words like sarcomatoid or scary words, I never like seeing that, or poorly differentiated. Rare tumors, sometimes there's one that you get back and it wasn't even on your radar, and you have to, like, PubMed it to kind of even figure out what it is. All of those that are rare, oftentimes it just changes our threshold for how we would do our Mohs. So those are things that we like to know about in advance. But I use the AUC app all the time, and it's really helpful if you have someone that might not necessarily meet criteria. The criteria are meant to guide decision making so that we're being judicious with our use of Mohs. But there are people who have a 3 centimeter superficial basal cell, where superficial basal cells off of the head and neck are not supposed to qualify, but it's in a field of radiation. Or the patient is allergic to topicals because they've had, I just found out today that some topicals you can't use if someone has a nut allergy, which I never knew. It's like for field treatment. So, there are certain cases that you can still choose to send for Mohs, but they need to be justified.
Interesting. Can you circle back to the nut allergy comment with the
I
topicals. Are you
I have
referring
not had a chance to look into this in great detail, but, one of the physician's assistants that I work with frequently sent a patient for one, and she came in with that report, and I was like, "Well, I was already thinking about doing Mohs on this just because of her overall health and needs," but that I was like, "Okay, I guess I'm not even gonna talk about topicals." I oftentimes will recommend fluorouracil or imiquimod for off face superficial lesions, whether they're squamous situs or superficial basal cells. But the patient was already coming with the plan for Mohs, so and I should have known because that particular person that dermatologist who refers to me is exceptionally thorough. But yeah, apparently there are some nut allergies that have cross reactivity with some formulations of topical chemotherapy and topical imiquimod.
Well, that makes sense. I know there's one specifically that actually it has peanut oil in there, and I know it's highly refined, but I didn't think about that at all, ever until today. So thank you for that.
Wow,
Yeah.
interesting. So in that same vein, are there situations where Mohs is appropriate based on the AUC criteria, but we might decide against it based on the patient's health or other comorbidities?
All the time, and I mean, you can tell that you guys are experienced because these are, like, the questions that plague dermatologists, right? And you guys are the primary dermatologist for patients, and you are the people who first face patients with surgical fatigue. And just to kind of put a label on it, surgical fatigue, patients who reach the point where they are hesitant to pursue surgical therapy. And I think if you're getting more than probably 4 skin cancers in a year, you're gonna develop surgical fatigue pretty quickly. So it's not uncommon for us to do other things for those patients, even if Mohs is appropriate to consider other treatments. Some of our very elderly patients, some of our patients with dementia, some of our patients with low life expectancy, and some of our patients who are just awful healers, we will consider other things like intralesional 5-fluorouracil or intralesional methotrexate, or there are some studies of doing PDT for some superficial things. There's some growing evidence that even imiquimod can be used for superficial and nodular BCCs. I don't think it's strong enough for me to recommend it routinely, but there are patients that we absolutely do that. And I think the key is probably finding a Mohs surgeon who thinks about the patient not just as a tumor, but as a patient and as a whole picture. And, there we're scattered all around the country. We're not all only tumor driven. And so I think finding someone who can build that rapport and care for the patient with you because Mohs is not always the answer.
Yeah, I work in a satellite clinic and often have elderly patients or those that are just in poor health, and the way I usually approach them is I tell them, "Look, you're in charge now, not me. So let's talk
Mhm.
about how you might wanna manage this, if at all, or let's pick out the ones that bother you. Which ones do you wanna deal with?" And that's how I kind of approach those patients.
Yeah, and that's a great idea. And sometimes those patients, you get the experience where you say, "That looks like a nodular BCC. I'm gonna ED and see it at the same time so that you don't have to come back." And every now and then, people make a mistake, and then we're dealing with a lot of scar tissue and something that's worse than a nodular BCC, but it's worth it for those particular patients. And, that quote is a great quote. I heard one from a fellow applicant once that I now use where I say, "This is your party, I'm your DJ." Like, we do this how you need to in order to you know,
Yes.
live your best life.
I
I
like
love
that.
that.
And it's so many nuances, after you've been in practice for so long, right? There's so many little nuances to managing patients, right? It's not always by the book. It's just
Mhm.
how do we approach this? And I have an exceptional number of patients in their 90s who they're tired. They don't want to do this. It's not gonna be the thing that ends their long life. But I think it's really helpful to really think about it beyond just the AUC. So, question, another, obviously we use Mohs for basal cell squamous cell carcinoma, but what other tumors or lesions are you typically utilizing Mohs? And I know there's some rare tumors that you mentioned already, but what are some of the most common things that you run into outside of BCC and SCC?
Yeah, I mean, I think those are the 2 most common. There's growing evidence and support for using Mohs with immunostains to do Mohs for melanoma. And our institution doesn't do that. We do something called slow-mos, which is overnight processing, where the path lab will use their immunohistochemical stains and tell us if we're positive and so forth. So a lot of practices will do Mohs for melanoma, so that's probably the third biggest. But we frequently do rare tumors. One of my clinical interests is uh, AFX and pleomorphic dermal sarcoma, which kind of are a little bit of a continuum. They're really two different beasts, but microscopically they can look similar. So that's a very common one. One thing that people may not know is that DFSPs, so dermatofibroma sarcoma protuberans, really long name, makes it sound very fancy, has a recurrence rate of up to 50% if taken off by general surgery or by surgical oncology. And with Mohs, it drops to 8%. So there are some tumors that are very beneficial to treat with Mohs. And so um, some of it depends on your Mohs surgeon and their comfort level. Some people won't touch certain types of tumors. Some people have had a lot of experience with them. And yeah, I think the best thing to do if you get a rare one and you read the evidence that says Mohs is reasonable is to reach out to your Mohs surgeon and make sure they're comfortable with it. We
With
love those rare ones. They're like the most fun, right? They spice things up, and we have a really uh, active tumor board where we involve surgical oncology and radiation oncology and medical oncology, and those are the ones that we spend the most time talking about.
So two questions kind of along those lines. With slow-mos, is that typically just for melanoma in situ, or are you doing that on full invasive melanomas as well?
So our threshold for doing it is we generally do it for the in situ tumors because that's got the longest duration of evidence for it. But anything that doesn't qualify for a lymph node, we'll pretty much do them all with slow-mos if they're in kind of sun-exposed areas. They are more demanding of the path team. They do cost more for the medical system because they require more staining and so forth. But I feel like you don't want to mess around with a melanoma. I want to make certain that I have complete margin checking. So just to make sure everyone remembers the difference, you send a normal wide local excision, they bread loaf the tissue. So if you picture a loaf of bread, they take individual slices and look at them. In doing so, they look at, I think the stat is something like 2% of the total margin versus if you do on FOSS margins, they look at the entire edge. And so it should correlate with a better prognosis. And in studies, it does look like it does. However, if it's thicker than 0.8 millimeters, or it's invasive and ulcerated, even if it's thinner than that, that's usually the point we're having the conversation about a sentinel lymph node. And that's the point where it doesn't make sense to put the person through two surgeries. So it's usually the surgical oncologists that are taking care of that.
Okay. What about Merkel cell? Is that something that qualifies for Mohs, or is that a surgical oncologist?
That is like a very hot topic. And the reason for it being such a hot topic is that Mohs works very well for local margin control. The problem in Merkel cell is by the time it's on the skin, there's such high risk of it having spread that usually you don't want to mess around and be tissue sparing. You really want to kind of take a solid whack at it and get that person to radiation as quick as possible. So I have done Mohs for Merkel. They're pretty easy to read on a Mohs microscope in, I think, 2 or 3 cases where tissue sparing was paramount. So eyelids, inside a field that had already been irradiated. Um, One patient who could not go to the OR, like for medical reasons, could not go to the OR. But for the most part, we hand those to our surgical oncologists. And even at places like Michigan, where the chair is the head of their Merkel cell group, he is usually just the quarterback sending people to Surg-Onc and Rad-Onc. It's not necessarily the mainstay anymore.
Excellent.
Yeah. So next question, what are your thoughts on field cancerization treatment? Should we hold off on doing that until after Mohs surgery? Is it okay to do it beforehand?
If you ask 100 Mohs surgeons, I'm sure you're going to get many different opinions. However, there's a couple things that are universally true. Treating with a topical agent within a couple weeks of surgery makes the field really messy. And it makes the epidermis sometimes look a little strange, and it causes a bunch of inflammation. So I don't usually like to do field treatment in the area I'm operating, probably for at least 3, maybe 4 weeks beforehand. I love it further before that. So, either treating the whole, if you have a spot on the middle of the forehead, you treat the whole forehead with Effidex for a couple weeks or with a Micomod, or you do PDT, but giving it enough time for the inflammation to settle down before surgery is great. I also love it afterwards. And so I think that it's a great adjuvant, neoadjuvant, or adjuvant treatment for Mohs.
Do you think is there a certain time frame that you prefer we wait before using those types of treatments after Mohs?
No, sometimes That's a good question. I guess it depends on the repair, but I have some people that I'll tell, within a week you can start because you're already gonna look a little bit of a mess from our Mohs surgery, so you might as well get it done. But probably at least a week.
Okay, excellent. Just curious, what field therapy is in your hands? What's the most effective? What do you find to be the most helpful?
I love the compounded,
Uh,
5-fluorouracil and calcipotriene. I just find that it works really well for people, and it's a little bit challenging for some of our patients on limited incomes who have good prescription coverage, where, you get the generic 5-fluorouracil from your regular pharmacy, and they don't have much of a copay, but I find that the compounded is so effective. I think that's probably my personal favorite, and for people who you don't I don't wanna say don't trust, PDT is a great option too.
Yep, I agree. And then kind of final question for you. So a lot of the I think success when it comes to Mohs and getting patients in the chair with our Mohs surgeon comes down to the counseling, right? Setting
Mhm.
expectations, explaining the
Mhm.
procedure to the patient, really kind of calming their anxiety down. So, how do you recommend that we better prepare patients and kind of set realistic expectations for Mohs? I know sometimes they go in thinking it's the tiny pimple of a basal cell, and they're shocked when it's a much larger, defect afterwards. So, any tips or tricks as far as the counseling session goes?
You know, I feel like one thing that is helpful, and I think about this in the capacity of me having to send people for radiation, for medical oncology. It's so much more helpful when I have been to one of those offices to understand what the experience is. So I'd encourage all of you to reach out to your Mohs surgeon and say, "Can I come work with you for a half day?" Just so if you haven't had the experience, you get to see kind of what happens in the office and you get to hear what your usual Mohs surgeon uses for their spiel. But I think, setting the expectation and knowing the practice is key. For example, our office, it's our policy that patients do not go to a waiting room. They stay in their same room during their surgery. It is our policy that their guests who bring them step out when we're doing the procedure. Um, we do a wave scheduling where I do a wave scheduling, some people don't. So setting the expectation for the patient that you're going to be there from 2 to 4 hours is usually kind of a standard amount to say 2 to 4 hours. And then to say during that 2 to 4 hours, a lot of it's waiting. That's helpful for people to know. Your surgeon's going to talk to you exactly about what's going to be done. And I don't think anybody ever tells patients that they won't have a scar, but for some reason, patients come in and tell me, they told me I wasn't going to have a scar. And, and you think there's no way. They probably said they're going to do the best that they can, the
Right.
best scar you can get is with Mohs surgery, but, making sure you set that expectation. You'll have a scar. You're in great hands. They do thousands of these a year, things like that are helpful. And then, if you get that sense that the person is really nervous, I think it'd be hard pressed to find Mohs surgeons not willing to do a consult. So if there's that person that you think would be much better off, either because they have unrealistic expectations or they're very nervous or something like that, you can always suggest a consult first. Um, and during that consult, we can assess, is this the kind of person that the tumor is so large we want outside closure with plastic surgery? The patient is so large, like emotionally, that they may need an outside plastic surgeon for closure. Um, so consults are nice for those patients that, either the tumor is really big and bad, the tumor is rare, or the patient is a special breed that needs a little extra handling.
Yeah, I had a patient recently, that I, biopsied and diagnosed, and I found a post on a social media page that they had posted inquiring about the Mohs surgeon I had referred them to and asking for, like, just reviews of that
Well,
surgeon, and so, thankfully, there was very positive reviews for that Mohs surgeon, but I just thought that was really interesting, so, obviously, her anxiety levels were very high, and she wanted to ask the entire, city. So, anyway, but Riley, I'm so, so grateful that you were able to do this with us. I have always had just a level of deep, deep respect for most surgeons. I think what you guys do is just an art. It is magical. It's wizardry, whatever you want to call it. But I really have a deep respect for it. So we appreciate you and all these really helpful tips today. So thank you so much.
Thank you very much for having me. It was great talking.
Thanks for listening, everyone. Take care.
Thanks for tuning in to SkinSync. Don't forget to subscribe to SkinSync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.